Hi, everyone, and thank you for joining us for another digital Infoday session. So my name's Caroline, and I'm the Senior Policy Officer at Myeloma UK. And tonight's digital event is about AL amyloidosis, current treatments, and future directions. Firstly, I'd like everybody to know that this session is being recorded, and it will be available to watch later either on our Facebook page or on our website. Before we hear from our speaker, I wanted to tell you about our organisation, Myeloma UK. Some of you may not be familiar with it. So I wanted to tell you a bit about who we are and what we do. So Myeloma UK exists to support all those affected by myeloma and related conditions. These can include smouldering myeloma, MGUS, and AL amyloidosis. We're patient-focused and aim to empower, inform, and support patients in everything that we do. As an organisation, we rely on the generosity and kindness of supporters who fundraise and donate. We receive no government funding, so your support is vital. We're truly thankful for your contributions as they allow us to continue our work helping patients, their family, and their friends. And it helps us put on events like this today. We will be popping information into the chat box, so website links, publications, things that we will think will be useful to you throughout this event. If you have any questions that you would like to ask our expert, please use the Q&A box. So you can find that either at the bottom or the top of your screen. We'll try to answer as many questions as we can throughout the course of the webinar. In this session, our expert will talk about AL amyloidosis, its possible symptoms and complications, and how they can be treated and managed. We will also cover the current research and future directions of this condition. We do get a lot of queries on our Myeloma UK infoline and Ask the Nurse email service about AL amyloidosis and what potential treatment options are. And so I hope this webinar will be able to provide some support to you all. So for today's webinar, I'd like to introduce this evening's expert, Professor Helen Lachman. She's a Professor of Medicine and Clinical Lead at the National Amyloidosis Centre. Helen, it's so nice to have you present for us in this webinar. I'd like to hand over to you, and if you'd like to begin your presentation.
Caroline, thank you so much for the invitation. And I'm very happy to talk to you tonight about AL amyloidosis. Could I have the next slide, please? So what we're going to cover on this talk is how AL amyloidosis is treated and managed, and then some research and future directions in amyloidosis treatment. So in AL amyloidosis, what happens is that amyloid deposits, which are protein which is refolded in an abnormal fashion to form fibers, deposit between cells, and that can damage both how body tissues work, and particularly that tends to cause things like easy bruising or a big stiff tongue, and how organs function. The protein that makes amyloid is a bit different between every single individual who has them. It's like snowflakes, it's all the same, but each one's also a bit different. And the pattern in which amyloid deposits in different organs is a bit different. That means that every patient with AL amyloidosis is unique, and the way that the disease affects them is also unique, and it closely relates to how the amyloid is deposited. There are patterns that we see fairly consistently. So AL amyloidosis is the commonest type of amyloid that we see presenting to the National Amyloid Centre, and we see between 400 and 450 new patients every year with systemic AL amyloidosis. The commonest organs that are affected are the heart, and that tends to present with a rather slow, gradual onset of breathlessness, sometimes with rhythm problems and with significant fatigue. We also see kidney involvement, which is often picked up with abnormalities on blood tests, but which can cause protein to leak through the urine and cause ankle swelling, and eventually kidney failure. And we can see damage to other organs and to other systems. And the things that we see that are most marked really are damage to the nervous system. And that could be either damage to the nerves that supply sensation to the hands and feet, We tend to see symptoms in the feet first, probably just because the nerves to the feet are longest and therefore most vulnerable to damage because it's a long, long journey. But we also see damage starting in fingertips, often with tingling, numbness, sometimes with some unpleasant lightning pains, and also damage to the bit of the nervous system that supplies automatic functions, such as control of blood pressure, so that you don't feel giddy when you stand up, control of bladder, bowels, heart rate, very occasionally control of sweating. Gut involvement can cause upsetting gut function, so with a feeling that your bowels aren't moving quite normally. People often feel full, very rapidly lose weight because they lose interest in eating. Can cause diarrhea and can occasionally cause bleeding. And involvement in the liver can happen. It's quite rare. And often what we see most is actually the liver just being very big and people getting pressure effects from carrying a very big liver. Can I have the next slide, please? Once the diagnosis of amyloid has been made, and for many people, unfortunately, that's quite a long journey because it does look very different from individual to individual and often comes on rather slowly, we then need to talk about treatment. And unfortunately, this is a disease which at the moment is not curable, but it is treatable. And the treatment is a bit sideways. So we can't at the moment give treatment that clears amyloid out of the body, although that's clearly what everyone needs. What we rely on is that the body can itself turn the amyloid deposits over. And so if you can slow down the rate at which new amyloid deposits are being made, we rely on the body gradually clearing away the amyloid deposits that are there, with the potential for things to first of all stabilize and then we hope in time potentially improve. In AL amyloidosis, the protein that forms the amyloid is a fragment of antibodies. It's made by plasma cells. These are usually clones, so these are sister copies of abnormal cells, and this is within the family that is the cancer called myeloma, although most of the patients that we see will not have frank myeloma. They will be on the road to myeloma. You can also see this with some forms of lymphoma and other rare conditions. And we borrow the treatment for that. The treatment for these conditions has got dramatically better over the time that I've been a doctor. But for most patients, we aren't talking about cure. We're talking about getting the condition sufficiently well suppressed that we can't measure it. And then when it comes back, treating again. And this means that these bone marrow conditions, these clonal disorders, follow what is called a relapsing and remitting pattern. And the next slide is actually going to show that as a figure. So what we mean by relapsing and remitting is that after the first dose of treatment, or first course of treatment, the aim of treatment is to get the underlying bone marrow disorder sufficiently treated that we cannot find it anymore. So the abnormal, potentially cancerous cells have all gone, can't be found if you do a biopsy and look for them. And the products, what they spill into the blood in form of abnormal antibodies, whether that is a paraprotein, which is a whole antibody, or light chains, which are fragments of the antibody, cannot be measured. So a complete remission is when you just can't find it at all. Partial remissions, we classify as very good partial remissions, slightly less good partial remissions, but when you've seen a very major knockdown, but you can still just about detect it. As long as you're in a remission, what you have is you are monitored, but because the risk of it coming back is very high, it's not 100%, 1 or 2 people will stay in a prolonged remission, but for the majority of people it will come back. You are always monitored. What we hope is that the relapse, which is when the condition comes back, with monitoring, is picked up on monitoring before people get unwell from it or notice any symptoms. And the monitoring is looking for these proteins to come back again. So there's monitoring looking for abnormal bone marrow-derived protein, either in the blood or in the urine or in both. And sometimes the monitoring is also with a repeat bone marrow test. And at the point of relapse, there's then more treatment, using the best treatments available at that time to try and get people back into a remission. And that's a cycle that people can go through on several occasions. And eventually, you may reach the point where there is no more treatments that the bone marrow condition is responding to. And then that is called refractory. That is when the disease is no longer responding to treatment. And at the moment is the point at which further chemotherapy isn't very helpful to you. Can I have the next slide, please? So what are the aims of treatment? Well, most people who present with amyloidosis are not presenting with a bone marrow cancer, in that it's not the bone marrow condition that is making people feel unwell. So when people have a bone marrow cancer, what they get is pain in their bones, because you can actually get holes in the bone from the cells, and that can cause pain and cause fractures. We tend not to see that. People can get high calcium. People tend to get recurrent infections because the bone marrow is actually failing. And it's extremely unusual for us to see that. What we see people coming to us with amyloid is symptoms from the amyloid. Some of those symptoms are quite hard to put a finger on, and are one of the reasons why the diagnosis is difficult and slow. And those are symptoms such as fatigue, which is very real with amyloid. It really does feel, often for people when they're presenting, like they're wading through treacle. Everything is really difficult, really tiring. You can have breathlessness, swelling, extra fluid causing swelling of the ankles, as well as breathlessness, loss of appetite, weight loss, easy bruising, damage to the nerves. One of the aims of treatment is to try and get all of this under control as much as possible and to improve quality of life. There is a difficulty with that, which we'll come on to, which is that some of the side effects from the chemotherapy drugs we use can make this worse. And sometimes, often, we end up giving more and more drugs, what's called polypharmacy, so that there are drugs to try and treat the underlying bone marrow condition, but then there are also drugs added in to try and treat both symptoms from the organs which are struggling from amyloid, but also from the side effects of chemotherapy, to try and keep people feeling as well as possible. It does mean that a lot of our patients complain that during the time of chemotherapy, we are making them rattle. The number of tablets you're asked to take is quite a lot. The hope is that with improving quality of life and treating the underlying bone marrow condition, this will also prolong life. And the life expectancy of people with amyloidosis has undoubtedly improved significantly over time. It's still nothing like as good as we'd like, and this is a very serious and life-threatening disease. We haven't had a magic moment, but nonetheless, year on year, decade on decade, the treatments are better and people do live longer. If, as I said, we can stop new amyloid being formed, it gives an opportunity for the existing amyloid to gradually be cleared away, and there is the potential both to stop worsening in organ function. It varies a bit from organ to organ. Some organs, particularly the kidneys, when they're too damaged, they essentially are working really hard and they get very exhausted, and there comes a point where we say the kidneys probably aren't going to get better. But what we hope to see is that organ function stabilise or perhaps get better, and certainly if there's a good treatment response, to stop new organ systems being involved. With chemotherapy, which is full-on, fairly toxic treatment, there always has to be a balance made with every individual, with discussion with them and their doctors, and looking at them as particular individuals and exactly how their disease has affected them, between what we hope are the balance of the benefits of treatment against the risks of treatment. This includes absolute risks, including risks of really serious side effects, infection, damage to nerves, potentially even death, against also the undoubted effect that chemotherapy has on quality of life. People do not feel as well on chemotherapy as they do not on chemotherapy, and we know that there is always a bit of a knock to quality of life when you're on high-dose treatment, and particularly on steroids, against the benefits that we're hoping in terms of reducing the rate of new amyloid formation and hopefully seeing amyloid regress. And one of the other things we talk to people about is that often you get the downsides of treatment quite early, because you get the drug side effects quite early. But the benefits in terms of treating amyloid, unfortunately, we often see deferred for quite a while, for weeks, months, sometimes even a year or two after treatment has worked. And so we don't expect that when we start people on treatment, that they will start to feel better immediately. It's often quite a slow job, and that doesn't mean that it isn't working. And we monitor the effect of treatment by measuring the amyloid-forming proteins in the blood, and that's often very reassuring that treatment's going the right way, even if it doesn't really feel like it to when we start. Could I have the next slide, please? Sorry, I have to take something off my screen, which is stopping me seeing my screen. So if we look at an overview of treatment, what are the aims of treatment? The aim of treatment is to control the underlying bone marrow condition to prevent the supply of amyloid precursors, of essentially the bricks to build new amyloid, and therefore stop new deposits being formed. And we do this by reducing the number of plasma cells, which are the antibody-forming cells in the bone marrow, the ones that are related to myeloma, essentially by poisoning them, and therefore stopping them make the light chains, which are the bricks that go to make the new amyloid deposits. And the aim of this is to slow the rate at which new amyloid is formed, so that hopefully it's slower than the rate at which the body is clearing it. And so we change the balance between growing amyloid to clearing amyloid and see things gradually get better. But this is often a slow job, and we can monitor that both with changes in organ function. Also, if you come to the National Amyloidosis Centre, often with changes in the scan. Treatment effect is monitored by measuring what's happening to the amyloid-forming proteins, usually the light chains. What's happening to the organ is measured by organ function, is measured by asking people how they feel, and also some specific blood tests. And treatment is, as I've said, often accompanied by supportive treatment to try and help with the particular side effects and complications of chemotherapy. They will depend a bit from agent to agent, but we're usually worried about accumulating extra fluid, about problems with blood pressure, about problems with appetite, and about risks of infection. And on the next slide, we'll have a look at some of those. So initial treatment choices depend a bit on what the long-term plan is. So in people who are either have single organ disease or do have underlying myeloma, and it looks like we're going to want to treat the underlying bone marrow condition more intensively, we may be talking about conditioning treatment with moving on to more intensive treatment, which is a stem cell transplant, very early. In other people, we will be talking, and to be truthful for the majority of people, we'll be talking about not heading straight for what used to be called a bone marrow transplant, but using cyclical treatment to try and get things under control in a slightly more controlled and less in one go fashion. At the moment, there is almost no treatment that is specifically approved for amyloid. We'll talk about that in a second. And so what we've done is we've borrowed the treatments that are approved for myeloma, because myeloma is much, much commoner than amyloid. This year, the first treatment specifically for AL amyloidosis was approved in Scotland. Unfortunately, at the moment, it isn't approved in England. And so we are still having to borrow the regime for myeloma. And we can't specifically prescribe about that. There's also, if you come to one of the big centres with an interest in amyloidosis, the potential for clinical trials, and there are a number of clinical trials that we're recruiting into at the moment. Could I have the next slide, please? So we're going to pause here and have some question and answers, and I will hand over to Caroline.
Thanks, Helen. That was a great start, a really great overview of the treatments and what patients can expect and what the treatments are actually doing to kind of make patients feel better and go into remission from AL amyloidosis. So yeah, as Helen said, this is the first question and answer session from today's event. I'll start off with some of the questions that we've had submitted in advance. So thanks to anyone who submitted a question ahead of today's webinar. If anyone has a question that they've just thought of or something they want to ask from the first half of the presentation today, just pop it in the question and answer box, and we'll try our best to get through as many of the questions as possible. So the first question we have today, Helen, is from David, and he was asking whether or not you think there will ever be a time when there's just one test that we could do to diagnose AL amyloidosis, rather than the big selection of tests that patients have to have at the moment.
So I think that's a really good question, and it's undoubtedly true that most people with AL amyloidosis have had a pretty long and frustrating journey to the diagnosis. At the moment, the diagnosis for most people relies on a biopsy and then staining with a particular stain called Congo red, and then we can see the amyloid deposits, and they stain, I'm afraid, rather a pretty pink, and when we change the angle of the light, you can make it go a very pretty green colour. It would be much better to have a single test. It would shorten the diagnostic pathway dramatically. The difficulty is that amyloidosis is a complication of another process. And for most people, proteins will not refold to deposit in this fashion. So I think there probably won't be a single test, but I hope very much that with advances in what we can do with looking at proteins in the blood, that things will get better. And there is a technique called tandem mass spectrometry, which is essentially where you can fire proteins through a laser, having broken them down a bit, and look in rather more detail at their structure. It's a very sensitive way of looking at proteins and at looking very specifically at exactly what a protein is. Essentially, they get broken down into their component bits. It's like taking a string of beads and breaking it down into each string, the string down into each individual bead, and then labeling each bead and then working out what the string would have looked like. And it's much, much more sophisticated than our current tests that we do in most labs for measuring proteins in the blood. We know that some proteins, based on the order of the beads in their string, are more vulnerable, more inclined to form amyloid than others. So I think there may come a point where we can look at light chains and say, these ones are higher risk and these ones are lower risk, and that we can better rank risk for people. But humans are complicated, and risk doesn't tell you whether you're doing it or not. And I suspect that there isn't going to be a single test, but I hope that that might move risk clearly up a hierarchy for people, and that you might end up with a report coming from the lab saying, we've looked at the light chains in this particular person. They look high risk for amyloid. Have you thought about amyloid? Which doesn't happen at the moment. It is possible that some of these proteins will form a little bit of amyloid in circulation, and that could also get picked up. The problem is the body's really, really sophisticated about picking up misfolded proteins and clearing them away. So finding a tiny amount of misfolded protein in the blood is potentially interesting, but also it may well happen to people with myeloma. But a lot of people with myeloma never get amyloid, and that may be because the misfolded proteins are flagged as being something that needs to get binned immediately. So I hope it'll get better, but I suspect that there won't be a single test. Sadly, in medicine in general, we're all very keen on our kit, and diagnosis over time gets better and better and better, but we tend to do one more test rather than one less. And each time we add a test in, we get better. But it's very, very rare that we end up dropping one.
Great answer to the question. The next question we have is from Robert. He's asking a bit about the risks of getting myeloma when you've already have AL amyloidosis.
And again, a great question. So if you have AL amyloidosis, by definition, you have an underlying bone marrow condition, which for almost everybody is on the road to myeloma. Clones, these bone marrow conditions, do change over time. And in theory, they can evolve into myeloma. It actually seems really very unusual. It's very rare for us to see it. We see relatively little myeloma compared to much lower grade conditions. I think what we may see over time is not so much that amyloid puts you at risk as myeloma, as that as conditions get better, and as treatment gets better, other conditions get better, is that we may end up seeing more people with myeloma that they've had for many, many, many years because treatment's been pretty good, eventually getting some amyloid because some abnormal protein has been hanging around, not for a year or two, which very sadly is what happened in the early 1990s, but for 20 years, and eventually it's formed amyloid. So it's possible, but I think the risks are pretty low. And actually, in terms of, for most people, I think the risk is more that eventually in people with very, very long-standing chronically managed myeloma that we may see a bit of amyloid.
It's really interesting, and I think a lot of people will feel quite reassured about that. The next question is kind of going back to treatments, and it's from Alan, and he's asking about whether age restricts the types of treatment that you can have for AL amyloidosis, and he says that he's 75.
Right. We try really hard not to be ageist. So people are treated according to them and how well their organs work and what doctors rather pompously call functional status, which is basically, can you run up the stairs for us? And the aim is to try and give everybody the treatment that is most likely to work for them without having all of us looking at each other going, I just wish we hadn't done that. So we really try not to, but time itself is a little bit ageist. And I'm not the same at 55 as I was at 25. And we do have to factor that in a bit. So stem cell transplantation is very limited for people over about 70. And that's not because anyone's saying we're not doing it for people aged over 70. It's because experience and trials over many years has suggested that the risks go up steeply. So the answer is there are no absolutes. And if somebody is great and everything works beautifully and they look really fit, you'll get anything you can be offered. But we do know that the slack, the reserves drop off as we all get a bit older. And therefore, the assessment of the benefit of a treatment against the risks is shifted. And one of the things that shifts it, not the only thing, is age. But I would say for everybody, what we try and do is look at them individually and plan the treatment that's best for them. And there isn't a hard cutoff that says you can't have it depending on exactly how old you are.
Oh, that's great. Another great answer. And like the anecdote you gave before that patients are like snowflakes. And although they're all amyloidosis, that
snowflakes, as in snowflakes, are all the same and all different, not as in snowflake generation, which is
true. Slight faux pas there. Moving on to the next question. So it's from Jacqueline, and she said that she tries to push. If you try to push yourself to walk or exercise each day, challenging your heart, will that help to kind of repair the damage that AL amyloidosis has done to the heart?
Right. So the answer to that one is yes, but no, but. So that people with AL amyloidosis feel tired all the time and are breathless is not because you're unfit and not because you're not exercising and not because of anything you've done. It's because there are amyloid deposits in the heart and it is stiff. It's like trying to blow up a really stiff balloon rather than a nice flexible balloon. And you cannot exercise your way out of that. This is not a lifestyle disease, and the complications of amyloidosis have got nothing to do with lifestyle. So you cannot exercise your way out of the damage of amyloid because it's not lack of exercise or willpower or being fit that did this. It's a really nasty rare disease. That said, particularly with the chemotherapy and the steroids, there is a risk of losing muscle and losing condition, which is very hard to get back. So we do like people to exercise, but it's not like being 20 and in the gym where if you push it really hard, you are going to make yourself better. If you push it really hard, you are going to feel terrible. And there is a risk that you will end up collapsing outside and end up in a heap in the pavement and need picking up. And potentially that things can get really bad. So what we say is it's really good to exercise. It's really good to keep your muscles going, but within the limits of what is comfortable. And it's fine to push it to feeling tired and a bit breathless. And you then sit down and have a rest. And the sort of rule of thumb I tend to say in clinic is if you push it to where you think I really need a rest, and 5 minutes later, after sitting down properly, you are still feeling absolutely dreadful, you shouldn't have done it. You should have done a bit less. If you push it to the point where you need a rest and 2 minutes later you're beginning to think, I'm feeling better, and 5 minutes later you're thinking, I will now stand up and do some more walking, you are at the level where you are protecting your cardiovascular function, you are keeping your heart, lungs going, and you're keeping your muscles going. So I sound like when I'm talking to the teenagers, do something, but don't think that you can force your heart to go back to normal, because the heart is really struggling with amyloid in it, and it's not going to get exercised out.
Brilliant. Thanks very much. Hopefully, Jacqueline, that answers your question. We're now going to pause on the questions for now and go back to the presentation. So, Helen, it's over to you for the second part.
Thank you. Next slide, please. So when we look at treatment, this is the sort of discussions that are had when you start about initial treatment. So in a minority of people, particularly if it looks like the underlying condition is myeloma, or if they have single organ involvement and we're not very worried about that organ, we might talk about going straight to high-dose treatment, which would be a stem cell transplant. For most people, we talk about standard or lower dose treatment, which is cyclical treatment with a combination of tablets or injections, usually taking part over cycles where each dose regime takes about a month. And there are clinical trials which sit in between the two and where we're looking at new combinations of pre-existing agents or new agents to see how they help. And for everybody, treatment is combined with supportive treatment, which is both aimed at trying to keep struggling organs as good as possible and also at preventing the known side effects of chemotherapy. And if I could have the next slide, please. So the sort of initial treatment options we talk about in the clinic are usually drug-based combinations. And at the moment, the commonest drug-based combination that we will use, if we can use it, and if we can fit it in line with current treatment recommendations along the lines of using myeloma drugs, would be a combination of daratumumab, which is a monoclonal antibody which targets myeloma cells and increases their kill, but which is not a chemotherapy agent. It's essentially a tag on them saying that this is a cell that we wish to get rid of. Cyclophosphamide, which is an old-fashioned chemotherapy agent, which has been used for many years for myeloma and for some lymphomas, and also I'm a kidney doctor to treat some kidney conditions, and bortezomib, which is a proteasome inhibitor, and which essentially acts. Cells continuously make proteins, recognize that they are not functioning, not properly formed, and that they need to get cleared away. And there's a rubbish bin system for clearing away proteins that aren't quite right within cells. And this system is called proteasomes, meaning breaking down of proteins, and bortezomib inhibits that. And essentially what you end up with a cell, if you inhibit that is overstuffed with protein that isn't working very well, and that really upsets the cell. It doesn't tolerate it very well. And plasma cells are very vulnerable to that because they're making antibody protein in large amounts. And therefore, they particularly don't like having their clearance mechanism cleared. They're much more vulnerable than other cells in the body that don't make so much. So that's our sort of standard combination. And this is combined with a steroid agent, which just makes the other agent work much better. It sort of primes the cells to be affected and poisoned by the other agents much better. That's usually dexamethasone. For some people, it will be prednisolone. And this combination tends to be called Daracibor D1 is our sort of preferred abbreviation, but you will find that we all use different abbreviations, and that is deliberately to confuse the patients. There are other combination chemotherapies which tend to be based on Velcade because Velcade has got a really good track record in being very good at killing myeloma-time plasma cells. Lenalidomide is a drug that has got some relationships to thalidomide. It's a next generation IMiD, and that is very helpful in also increasing cell death, in changing the microenvironment, and increasing remission rates in patients with myeloma. It usually has to be combined with something else. Cyclophosphamide, thalidomide, and dexamethasone was the drug combination that really changed things for us, and which we used before lenalidomide was much more available. We don't tend to use it so much because lenalidomide is often a little bit better tolerated. Melphalan and dexamethasone is our old warhorse. This is what we used when I was young. And it's still a good combination. Melphalan is an old-fashioned toxic alkylator. It is pretty good. It does eventually cause bone marrow damage, so one may not be able to go on and do a stem cell transplant afterwards. But what we often find with all advances in drugs is that eventually one may go back to the old-fashioned drugs because they can sometimes work when the new drugs haven't worked. And the other thing is that melphalan plus dexamethasone at fairly low dose can be very well tolerated. So it's not a bad drug to use in people who are a bit fragile, and it can be used at fairly low dose. Most of these regimes can be given largely orally and based from home with weekly clinic visits. Velcade can either be given as a subcutaneous injection or infusion. We now tend to give it as a subcutaneous injection. But these regimes are largely tablet-based with an injection under the skin once a week. Could I have the next slide, please? High-dose therapy, stem cell transplantation, is what we use now instead of bone marrow transplantation. It's incredibly rare now for somebody to have a bone marrow transplant. And at its simplest, the aim of stem cell transplantation is to do a cleanup operation. So what happens with stem cell transplantation is initially there is some treatment of the sort that I outlined on the first slide, on the previous slide. And the aim of this is to try and kill as many of the myeloma-type amyloid-producing cells in the bone marrow as possible. So to get that number down as low as possible. You don't want to do a bone marrow transplant without having got the bone marrow into as good a remission as you can with first-line treatment. Once you've achieved as good a remission as you can, there is then injections of drugs to encourage precursors, which are what you can build an entire new bone marrow from, out of their comfortable home in the bone marrow and get active enough that they come out into the circulation. Once that's happened, and you can measure that with blood tests, we get people to come into a day unit and essentially have a couple of cannulas in and have the blood taken out of one arm, pumped through a machine, which separates out the cells from the rest of the blood. The blood is returned. The cells, which are the starter from which a new bone marrow can be built, are harvested, and when there's enough of them, and we like millions of them, they are frozen. And that is the starter kit to grow a new bone marrow, and then it's safely in the bank. There is quite good evidence that normal bone marrow cells are better at coming out and better at surviving the collection process than abnormal precancerous cells. So having cleaned the bone marrow up with the induction treatment, you tend to also see that the process of mobilization and harvesting means that you also get a relative drop in the number of cells you don't like the look of the cancerous precancerous cells compared with normal cells, because normal cells are better at being immobilized and surviving harvesting. Patients are then given a high dose of chemotherapy, usually melphalan-based. The aim of this is to try and kill any remaining abnormal cells in the bone marrow. Unfortunately, that dose is big enough that it also wipes out most of the normal cells in the bone marrow. The bone marrow would recover, but it would take a very long time, and people, whilst the bone marrow are recovering, are very vulnerable because you need blood. And if you're not making any blood, you're vulnerable to bleeding, you're vulnerable to infection. It's a very long and miserable time. So in order to not have the high risks of being very miserable and of not surviving because you need a bone marrow, after the high-dose melphalan has been through as a clean-out agent, has poisoned the bone marrow, it also has a bit of an effect on the gut, because the gut, we shed the lining of our gut every day. So those are also very rapidly dividing cells that get quite hit quite hard by the chemotherapy. Cells that aren't dividing aren't nearly as bothered by chemotherapy. So it's gut lining, hair that really minds, and the bone marrow. The harvested stem cells are then pulled back, and they will circulate in the blood, and then they will go back to the bone marrow, settle back down in again, start growing and repopulate the bone marrow. And again, we know that normal bone marrow cells compared to cancerous cells are better at doing that. So high-dose therapy isn't just the melphalan that's treating the underlying bone marrow condition. The induction treats it, treatment treats it as well, but actually the process of harvesting, storing, and then repopulating the bone marrow all also favour normal healthy bone marrow against the clone. Bone marrow transplantation is not without risk. It was for many years our best treatment, and we knew that. So we knew that what we were looking at was what was undoubtedly a treatment that was better than anything else against a treatment that carried more risks, and it also carried the risks all in one go. And once you've had the melphalan, you can't take it out again. So once the melphalan's gone in, you are committed to completing a stem cell transplant process, because there isn't any way that you can say, I want to stop this now, I don't like the look of this. With the monthly chemotherapy regimes, if things are looking quite rough, you can stop for a month or two and let people recover. What's happened with time about stem cell transplantation is that the newer drug regimes, each one has got a little bit better about matching stem cell transplantation. So stem cell transplantation is a really good treatment if you respond to it. Not everybody does, but if you go into a complete response from stem cell transplantation, it was probably the best treatment to have. It gets things over in one go. And it leaves you with quite a lot of options afterwards if it's worked well, if you relapse in the future, and you might do. And it gives, we know from previous studies, the best chance of a good long remission before you need treatment again, and possibly of never needing treatment again, although that is not something that we promise people. But the choice has got less clear, which is good over time, because the new agents, each of them, begin to match. Except you're talking about prolonged treatment with the new agents month after month after month of treatment, compared to what we hope, if you have a complete response, and not everybody does, to a one-off treatment. It's not. So I think what I'm really saying is stem cell transplantation is a very good treatment. It is less clearly now the best treatment so much as a different treatment with different advantages and disadvantages. Nice to have the option if you're offered it, not a disaster if people tell you that you are not entirely suitable for it. People with bad amyloid in the heart, we're very concerned about risks, we wouldn't recommend it. People with very bad kidney damage, we have major reservations because this can be too much for the kidneys. So the number of people to whom we offer this is quite low, and hasn't gone up because we've had alternatives to offer them. Could I have the next slide, please? So the aim of treatment is to get you into a remission and for the remission to be maintained. And what we'd hope now, and what we see for the average person, I have to say, well, we talk about average figures, which we tend to talk about as median. That is, if you take everybody and you put them in order from the person who's done best to the person who's done worst, and you take the one in the middle. Our median responses to treatment and our median remissions after first treatment now last years. But these average figures are wrong for everybody. So you need to know that when we talk about average figures, we're not lying to you, but we're wrong for everybody, because for half the people we're too optimistic, and for half the people we're too pessimistic. So it's ballpark, but there's only one individual in a big cohort will get the average. But we would hope that if you go into a really good remission after your first treatment, that you should have a good long period, hopefully of several years, before you need to be treated again. But people vary. Some people will relapse more quickly. Some people will then spend many, many years before they need retreating. How we treat at relapse depends quite a lot on what happened with your first response. So if you responded really well to your first treatment and you had 8-9 years from your first treatment, we might just repeat it again because it had clearly worked really, really well. If you had not tolerated your first treatment well, or if it didn't last very well, we would talk about changing regime to something that works better. We use the same playbook as we used for our initial treatment, but what we say to everybody is travel hopefully, because the drugs we're using now are very different from the drugs we used 8 years ago, and we're not quite sure what will happen in another 8 years or 10 years' time. So for some people, we will add in a new agent, or we'll add in a different agent. We are somewhat constrained by what we can do in terms of controlled prescription around treatment for chemotherapy. There is actually policies about the order we use the drugs, and we need to fit in with that. But we would hope to retreat with the best agents that are available to us at the time. For some people, there is an issue, particularly around kidney failure, that people have done very well with treatment, but their kidneys have failed. And kidneys, once they're working at about less than 20-25% of normal, and we calculate that from a blood test, you can't tell from how you feel, tend to eventually get exhausted. It's just too much to ask for a fraction of how much kidney is working to keep going forever, and they get exhausted and eventually they stop working. And for those people, we then think about organ transplantation in AL amyloidosis. When we think about organ transplantation, we try and break it down into being fairly simple-minded about it. So we think somebody who's getting a kidney, you've got to think about whether they're well enough to have a transplant operation and to have the long-term treatment that you need to stop the kidney being rejected. So we wouldn't talk to somebody about having a kidney transplant if we didn't think they were well enough for the operation or for long-term immune suppression. We then think about what's happening with the amyloid. If their amyloid is getting worse, we need to do something about their amyloid before we put a new kidney in. If their amyloid is stable or getting better, we can think about the kidney. And we think about the transplant from the point of view of the kidney as well. It's like rehousing a child or a puppy. You're sort of thinking, is this going to be a good home for a new kidney? So you need to be well enough to have a kidney. We need to really believe that the kidney is not going to get affected by amyloid or another disease. And that if you get a kidney transplant when you have amyloid, or indeed another organ transplant, do we think that amyloid is likely to go into the new organ? And if so, we would want to treat beforehand so that we could say, hand on heart, we didn't think it was likely to go in. And is there a plan so that if the bone marrow condition comes back, we know what we would do to treat both you and the new organ with chemotherapy? And if there is a plan, then we'd say, and you're otherwise well enough, we would say we'd be very encouraging about doing it. And the data from our centre is that the relatively small number of people who've had organ transplants for AL amyloidosis have done very well. That's partly because they've been very, very carefully selected. But if you are careful about who is offered a kidney or a heart, and all these thoughts have gone beforehand and people have been carefully selected, actually they do very well. Kidneys we compare against diabetes, which is a very common cause for needing a new kidney, and we do better than diabetics. So in the right person with a good treatment plan, there's no reason that you can't have a kidney transplant. Sometimes it's a reason thinking about high-dose transplantation. To be honest, sometimes it isn't, because once we've got a kidney in, there's all the risks I talked about high-dose transplantation before, but then there's also a kidney, which is a new transplant, which we really want to protect. And sometimes we end up using the other regimes we've got, and if they look equally good, we may decide that we're never going to go for the risk of a high-dose transplant, of a stem cell transplant and high-dose chemotherapy, because if we're doing well from a bit lower risk, we are very protective of the new organ. And then there's also, at relapse, the options of clinical trials, and there's a number of clinical trials open, and what's open and available depends on which centre you're in, and also the particular trial at the moment. I can touch on them at the end. Could I have the next slide, please? So what sort of options do we talk about? So there's carfilzomib, which is a new generation proteasome inhibitor. It's one on from bortezomib. You can tell this because it's got the same end. So drug families share the final syllable of the drug. So you can always tell what's in the same family by whether it has got the same final syllable. With dexamethasone, and that is a good proteasome inhibitor, actually with a slightly better side effect profile than Velcade, although there's still a little bit of risk of neuropathy. For people who haven't had daratumumab before, that can be put in. Ixazomib is another proteasome inhibitor which can be used in combination. Pavabinostat works by decreasing the ability of cells to manage their DNA, their nucleus, and can be used in combination. Pomalidomide is a next generation of lenalidomide, and then there are other monoclonal antibodies and the clinical trials. Next slide, please. So what sort of side effects do we worry about from chemotherapy? Well, all of these agents are targeting the bone marrow, and that means that the bone marrow suffers a bit and you can get low counts. That can be anemia, making people feel tired, low platelets with an increased risk of bleeding, and low white cells with an increased risk of infection. And that can be both bacterial infection, but also fungal infection and viral infection. Some of these drugs upset the kidneys. The kidneys are often a little bit borderline anyway, and they're having quite a rough time, so we monitor them quite carefully. Fluid balance, particularly if the kidneys or the heart are upset, is quite difficult. It's the job of a normal, healthy, functioning kidney and heart together to keep the right amount of fluid on board. If they're struggling, it's hard for them to do that, and we often need to add in water tablets to try and support that. Sometimes this is also complicated by low blood pressure, and we had to add in some drugs to try and help the blood pressure stay up. Upset hearts can sometimes have irregular heart rates or rhythm, and you may need to have drugs added in to try and stabilize the heart rate. There's agents like amyloidosis for most people, but there are other agents we sometimes use. Many of these drugs, particularly proteasome inhibitors, can have a bit of an effect in poisoning the nerves. That causes peripheral neuropathy. We like to know about that early so that we can stop the drugs early before it causes damage. Although we worry about bleeding from low blood counts, some of these agents, particularly lenalidomide and its relations, increase the risk of blood clotting. And if your kidneys are wasting healthy blood protein, which is called nephrotic syndrome, that risk is increased. And for everybody with AL amyloidosis, we worry about nutrition. People are often feeling really not very interested in food, not very hungry, have upset guts and a sore tongue. Most people we see have lost a significant amount of flesh weight. And we don't like people losing too much weight because you really need the energy and the muscle in order to cope with treatment. Generally speaking, managing side effects is a combination of protocol drugs, which we do because we can predict what side effects are going to be, and very closely monitoring blood tests and asking people about how they're feeling and trying to put agents in early. And what we don't want is to go from terrible fluid overload to feeling like you're going to collapse when you stand up. So rather than having dramatic changes, the aim is to do very small fiddles and keep people as good as possible without letting things get very out of control and then having to do dramatic interventions to try and shift extra fluid, manage breathlessness, because people often don't like very rapid changes. It's better to keep things much more balanced. Could I have the next slide, please? So we've talked about this. So prevention of infection is regular antibiotics, antivirals, antifungals. This is acyclovir. This is fluconazole. This is antibiotics such as doxycycline. People at risk of thrombosis will be put on blood thinners, and now we often use the DOACs, which we don't need to monitor. So that's apixaban or related drugs rather than warfarin, and we don't need to do blood tests for that. Heart stabilizers, amiodarone is our go-to drug of choice, but there are other drugs depending on what the heart rate is doing. The blood count may need encouraging, the bone marrow may need encouraging to make more normal healthy cells. GCSF encourages the production of white cells. EPO encourages the production of white cells. Fluid overload, we use water tablets, which are diuretics, to try and help you pee out water and salt, but that needs to be combined with watching what goes in through the mouth. So although we're very keen that people do eat and drink, we tend to ask people to monitor just how much fluid they're drinking and also how much salt is going in to try and mean that we're not relying on diuretics to force it out again. Kidney function, this is where I don't entirely agree with hematologists. It's really important to control fluid balance. It's really important not to be clinically dehydrated, but you can overdrink and then that makes you breathless. So there is a balance, and we tend to say don't drink too little, which is less than a litre and a half a day, but you gain nothing from drinking a lot. The Daily Mail is wrong. It is not good for you to drink 4 litres a day. It really isn't. And food supplements and dietitians and keeping your weight up is really important. It's something which we all tend to fail on. I would say it's really important to try and keep eating, often little, and often helps more if you're not very hungry than trying to get 3 proper meals down you a day. But a lot of people end up losing quite a lot of weight and muscle, and that's not good for them. Next slide, please. So what's going to happen in the future? Well, what we would like to see is treatments that specifically target the abnormal plasma cells so that we get fewer side effects from chemotherapy, because we're really only going for the cells that we want to get rid of and leaving the other normal healthy body cells alone. It would be nice to stop the light chains that are being produced as part of the abnormal plasma cell clones from forming amyloid. It would be much easier to treat these plasma cell clones or just monitor them if they weren't forming amyloid, and so stopping the amyloid formation by preventing the light chains collecting together would be great. Drugs that specifically clean the amyloid away would be fantastic, and would mean even if you needed the bone marrow treated, it could be done later when the amyloid had gone and organ function was better. And it would be really helpful to pick up amyloid earlier, particularly amyloid in the heart, which is the major killer and which also tends to be quite hard to diagnose because people get rather non-specific symptoms. And so there's a lot of interest at the moment in trying to improve the imaging of the heart to pick up amyloid, and new imaging modalities, particularly things like PET, CT, and fluvetavir tracers, which may improve our sensitivity for that. The problem for that is what I was saying about doctors being very keen on new expensive pieces of kit and new expensive tests. They will be lovely, but they're not going to be something that's going to be available in every hospital. Next slide, please. So targeting the plasma cells, there have been enormous advances in the treatment of myeloma. We'll want to keep borrowing them. But it would be nice to know in AL amyloidosis, where the clones are a bit different from myeloma, we're often a bit lower grade, a bit less rapidly dividing, to see specifically in amyloid how best to combine them to get best cell kill. There are a number of novel drugs on the horizon. CAR T treatments are using next generation tissue-based therapies to use the immune system to kill the abnormal cells, and that's very tempting. And then there are a number of new agents. There's belantamab, which may be very helpful in patients who've multiply relapsed and which is well tolerated except for some eye toxicity. There's bispecific antibodies, which is when we use the antibody therapy, but we're targeting several different bits of the plasma cell to try and increase sensitivity and kill. And then there's venetoclax, which is proven very useful in CLL, which may also have a role in AL amyloidosis. So this is largely, again, borrowing drugs from other regimes, what's called repurposing them, to see whether they're going to be particularly useful in AL amyloidosis, and whether we use the same doses or whether we would use a different dose or regime than is used in treating myeloma, CLL, or other common regime and commoner bone marrow conditions. Could I have the next slide, please? And then in terms of stabilizing light chains, it would be nice to be able to interfere with the protein folding of light chains and stop them clumping into amyloid. There have been some interest with doxycycline, which is an old-fashioned antibiotic, and which may actually slide in between the new refolded light chains and stop them essentially being able to hug each other. And it may be that there are other drugs that we can use that do the same things, that are small enough that they can actually slither in between the cells and stop them being able to wrap around each other and keep themselves stabilized. And that would just mean that the whole amyloid structure might become a bit less stable, more inclined to fall apart, easier for the body to clear away. Next slide, please. And then there has been interest for many years now in using monoclonal antibodies to try and recognize proteins when they're refolded as amyloid and see whether that encourages the body to help clear them away. And there are two studies going on with this. There's an agent called Kale, and Ashu Vichalika is the largest recruiter in the world for the two Kale studies, which are running at the moment, and which are looking at people with advanced cardiac amyloid and slightly less advanced cardiac amyloid to see whether adding this into treatment improves outcomes. And then betamumab was previously called an even worse name, which was NEOD001, and is a monoclonal antibody that had previously gone through trials, was briefly dropped because the trials didn't look very encouraging, but then the data was reanalyzed and there was a suggestion of benefit, and that again is going back into clinical studies. So the aim is that monoclonal antibodies that bind to amyloid fibrils and target for the body as being something that the body should try and clear away by the immune system. And if that can be encouraged, that would speed up amyloid clearance, which is really what we would all like to see in terms of treatment. And it's very exciting that there are clinical trials back on with these, and we'll wait to see whether they're a benefit. I think they will always have to be used in combination with something else. And next slide, please. Q&A, and I've slightly run over time, sorry.
That's okay. That was brilliant, Helen. It's really exciting to see just how many potential new treatments are in the pipeline and potential new ways to treat AL amyloidosis could be here soon. Yeah, like Helen said, we're running a little over time, so it would be great for those who are on the call if you can stay on. But if you do have to rush off, just to remind you that it's being recorded, so you can come back and watch the end of the session at a later date if you want to. So moving on to the kind of last, the second question and answer session, we've had a question from Steve, and Steve was asking about the recent news about the data Cybord appraisal and how NICE has not recommended the treatment, and he was asking specifically whether that will affect access to daratumumab at relapse.
So we hope to appeal that. because it is very disappointing. I mean, at the moment, the access to Darasibod D is using myeloma criteria. So if the bone marrow looks consistent with myeloma, we can still go down the myeloma pathway. And then it shouldn't make a difference. But the difficulty is at the moment that technically amyloid is not regarded as a myeloma defining criteria. So for people where the bone marrow doesn't look like myeloma, we have struggled to know whether they can get daratumumab. And given that the data from a number of trials looks encouraging, I mean, that does seem unfortunate. And we have been very encouraged when Scotland said yes. So I think it's a watch this space. But for most people, if the bone marrow looks that it can be defined as myeloma, we can still stick with that pathway.
Just to mention that, I think Myeloma UK were very disappointed in the decision as well. So we are actively working on appeal at this point. So to, try and overturn the decision. I think there is the news story is in the chat, but we also have said that if patients want to get involved, that they can write a letter to their MP to kind of voice their disappointment at the decision and to make them aware that they are supporting our appeal. And there is a template letter available for people if you want to use that. And I'm sure it's been posted in the chat. Next question is from Neil, and you've mentioned a little bit about clinical trials and you've talked about them. Are there any current clinical trials that you think are exciting or that you think are going to change the dial, and could you give us a bit of an update on those?
So I think the Kale study is very exciting. Andromeda, which has been published recently, which has been looking again at combination chemotherapy led by Professor Wichalika at UCH, has also been very exciting. I think one has to say, in all honesty, at the moment, there isn't something that's a complete frame shift. We haven't got the new drug that is going to cure myeloma and cure AL amyloidosis by getting rid of the plasma cells. That's what everyone would like. What we have got, though, is more and more new agents to play with and gradually improving outcomes. So it would be very nice to have an antibody treatment for amyloidosis. And I think that those are back in clinical trials is very encouraging. It may be that we will end up that this first generation of antibodies aren't the ones we use, but if there is evidence that this works, there's always the chance to get newer and better antibodies. I think the evidence that improving drug regimes works and keeps giving benefit for people as they go from first-line treatment to second-line treatment to third-line treatment, it's not nearly as lovely as saying we've got this new drug and you will only get treated once and it will work forever, which is what everybody wants. But these gradual improvements have been dramatic through my career. And we do talk to most people now about a life expectancy of years, not months. And that has been a major change over the last 20 years. And I very much hope that will continue.
That's a great answer. And it's amazing to see the progress in terms of life expectancy, and just really exciting to see that there are AL amyloidosis clinical trials happening that patients can join, which is quite an exciting step in itself. Unfortunately, that's all the time that we have for questions today. So thank you for answering all those questions. Great answers. So I hope a lot of patients are reassured with those. I'd like to ask you if you could just give us a quick summary or overview of everything that you have told us about today.
So thank you very much. So what we've covered is how AL amyloidosis is treated, both with chemotherapy regimes, but also with supportive care, and future directions in AL amyloidosis treatment, both with what I hope is going to be gradual improvements in chemotherapy, but perhaps also with a new generation of specific anti-amyloid treatments, which I hope will be used in combination with chemotherapy. And I'd just like to say thank you very much for asking me and for all the work that Myeloma UK is doing in supporting patients with amyloidosis, which is a rare disease and people really do need the support. So we're very grateful. And finally, the take-home messages. AL amyloidosis at the moment is not curable. It's a chronic disease, but it is treatable. And we hope that most people will spend more time in remission than in relapse. And that for most people, this will be compatible with a reasonably good quality of life and with much longer life expectancy than we saw 20 years ago. There are a number of different treatment options available both at new diagnosis and at relapse. This is often combined with supportive treatment to help the struggling organs, and treatments will be discussed with everybody on an individual basis to try and find the treatment they will tolerate best and is most likely to work for them. Clinical trials are going on in rare diseases, which is great and relatively new. We hope that both using drugs which have been used for other diseases and are being repurposed in amyloid and these new specific anti-amyloid treatments will lead to further improvements in outcomes. Thank you.
Thank you, Helen. That was a great overview of the take-home messages from today. Just before we finish, I just want to highlight some of the resources from Myeloma UK that many of the people watching today might find useful. And you'll see a range of them here. You can find them on the website, myeloma.org.uk/ALAMI. There's the guides, treatment guides, and the really great magazine, which is AL Amyloidosis Matters, and it goes out once a year. I'd also like to highlight Myeloma UK Information Support Services. We have our Infoline and Ask the Nurse email service, where our information specialists are available Monday to Friday from 9 to 5. As well as all the publications, the info packs and info sheets mentioned in the chat. There are further publications to download, as you've seen on the previous slide. There's also all of our previous digital Infoday sessions are on the website and the YouTube channel for you to watch, including an earlier AL amyloidosis webinar, which gives you an introduction to AL amyloidosis, its symptoms and complications. We also want to highlight a couple of our other services that you may not be aware of. So there's the Peer Buddy service, and it was launched this year, and it gives patients and carers a chance to tap into the knowledge and experience of other people who also have AL amyloidosis or are caring for someone with AL amyloidosis on a one-to-one setting. We also have, it's called a myeloma discussion forum, but it is open for AL amyloidosis patients, and there's a number of AL amyloidosis chats there. So if you want to talk to people in the forum and just get some support from others. And lastly, there's a range of support groups that you can join across the UK and meet other patients, carers and their family members. Hopefully the link, I think it's just gone up on the chat, but it can tell you where your nearest support group is, if that's something you're interested in joining. And that's us. We've come to the end of today's event. So thank you very much, Helen, for speaking with us this evening. A really great talk. Lots of interesting information for everybody. So yeah, I really enjoyed it. We'd also like to thank everyone who has joined us tonight, and I really hope you did find it as helpful and as informative as I did. If we didn't answer your question, or if you are thinking afterwards that was a question you wish you could ask, please do get in touch with us. You can do that via the Infoline or the Ask the Nurse email service, and someone will be in touch to answer that question. And just lastly, I just want to say a thanks to our supporters, and it's because of you that we can provide free digital events just like this one for patients and their families. So if you would like to support the work of Myeloma UK and help them to continue with free webinars like this, you can visit myeloma.org.uk/donate. If you want, you can rewatch the webinar at any time As we said, it will be posted shortly on the Facebook page and on the website. Thanks again to Helen. Really great webinar this evening. And thank you to everybody for joining us. And I really hope you have a great evening. And good night.
Good night. Thank you very much.
Thank you. Bye.